If you say so. All right, so when you're talking about a myocardial infarction, it's really dependent upon which coronary artery is involved. We typically talk about a Q wave or a transmural, but there is also what is called a subendocardial, where you do not have a Q wave developing. As far as ST elevation with the development of a Q wave, that's the where the Q wave is large. The Q wave has to be more than one small box and 33% of the subsequent R waves. So it gives you an idea of the size we're talking about. In non-ST elevation, you end up actually having ST depression and some serum markers, and these folks are at risk of ending up developing an MI. So it has to do with the presence of occlusion and how much collateral circulation you have. You should know where each of the leads are on a 12-lead EKG. That's kind of a basic. These three on the bottom here are usually lead 2 that they show, but it's really any you can program it to show any 3 you want as far as that is concerned. So again, each of these leads look at a specific part of the heart, and we'll talk about how they're aligned with each of the areas of damage. So we end up seeing T waves becoming large, in fact, to the point where the ST segment elevation looks like a chair and seat, or it's called a fireman's hat. Different ways to look at it. Development of the Q wave, the development of poor R wave progression, and I'll show what that looks like, and then finally the T wave inverts. So in the hyperacute phase, you just see an elevation in the T wave, or a tall T. That in and of itself is typically not seen, because by the time they present to us, they're already in this secondary letter B here, where you end up having ST elevation along with that tall T. As it progresses, then you start having the T wave flipping itself over, and eventually, once it's fully evolved, you end up having a Q wave present, and that Q wave will remain forever, even once the T wave returns to an upright position and of normal size. So this is the evolution of an MI. Okay. This is what it's talking about, R wave progression. Under normal conditions, as you go across precordial leads, the R wave becomes larger and larger. Can everybody see that? R wave defined as the first positive deflection after the first positive deflection of the QRS complex. Here you have poor R wave progression, where you don't really see any change in R wave as you go through the leads. And that's a sign of a myocardial infarction. The right coronary artery is predominantly involved in feeding the 2, 3, and AVF. The balance of them are by one of the branches of the left coronary artery. We'll talk about which branch it is in a sec. You don't have this in your text anymore, and I wish they did, because it's a great picture. But you can see we're talking really about the 4 different walls being involved. Let me see if I can draw this. We think of the heart as a box. You have septal here. You have inferior there. You have anterior there. You have lateral there. And this is your atrium. So we don't talk about that top at all. But those are the walls that we're dealing with. First of all, looking at the inferior wall, leads 2, 3, and AVF. And here you can see the inferior portion we're talking, and it's fed by the right coronary artery, right there. Here we have the septal, in dark blue, V1 and V2. It's fed by the left anterior descending. We have the anterior wall, again fed by the left anterior descending, V3, V4. And in everything that looks left, lead 1 looks towards the left shoulder, leads AVL looks towards the left shoulder, V and 5, V5 and V6 are along the lateral border, and they're all looking at the lateral wall. Okay. So you can see where the different leads point to in a specific direction. So if I look at this, I see changes where? Where do I see ST elevation and development of a Q wave? And if I see 2, what should I look at next? AVF, 4, 3. And all 3 of them have changes, ST elevation. Now notice that there's a depression in AVL. That's what we're going to call looking at reciprocal changes. So it's not looking at the front, it's looking at a different area. So it's an inferior wall MI. And which coronary artery would we suspect to have an occlusion? Right coronary artery. I would feel very comfortable having you identify where the infarction is and which coronary artery is involved. Clinically, these patients are going to appear differently. Typically, inferior, if you think about where the inferior wall is, that's the portion of the heart that is sitting right above the diaphragm, right? So patients who have inferior wall MIs often complain of nausea and vomiting and indigestion. Okay. What else does the right coronary artery feed? The right ventricle? Okay. So right ventricular infarcts can also be associated with inferior wall, which is why they would get a right ECG tracing to identify it. It's also associated with posterior wall, because that inferior also feeds that back part. So you might get what we're going to call posterior leads, where we're looking at V7, V8, and V9 going across the back. The right coronary artery also, oh good God in heaven, Rick, stop. The right coronary artery also feeds your node, and your sinus node, and your AV node. So it's associated often with blocks. An anterior wall MI, fed by the left anterior descending, is associated with loss of blood pressure, cardiogenic shock. So where the MI is very important. Not only so we know which coronary artery has to be treated, either with angioplasty or stents or bypass, but it also dictates what kind of clinical picture we're going to end up seeing. So here's those reciprocal changes, where here's where the damage is, and we're seeing the ST elevation, and here's where we're seeing the ST depression, because it's a reciprocal looking at it. And you can see the zone of ischemia, zone of injury, and then finally the most innermost, or the outermost ring, the zone of infarction. Lateral wall, let's start with that one. Lateral means left. Anything that looks towards the left side of the body is going to be, is going to tell us about the lateral wall. So 1, AVL, and V5 and V6. This is supplied by the circumflex branch of the left coronary artery. And it can have situations where it has an extension to either the anterior wall and even possibly the inferior, because as that circumflex wraps around, it feeds part of that inferior wall. We'll see reciprocal changes in V1, and because the circumflex can feed some of the blood flow to the AV node, you can end up having blocks associated with this one also. It's not, when I'm trying to find EKGs, it's often very hard because the septal, the anterior, and the lateral are all fed by a branch of the left coronary artery, and often they're there together. So you'll have an anteroseptal or an anterolateral, a combination of the two of them together. It makes it really hard to decipher. So here's my left circumflex artery, diagonal, and 1L, and 5 and 6. So it's looking at the lateral wall. And if you look at the EKG here, I have some ST depression. Yeah. AVL in 5 and 6. Inferior points down, so anything that points towards the bottom, 2, 3 in AVF, and some reciprocal changes in lead 1 and lead L. This is fed by the right coronary artery. As we talked about, you'll see blocks developing, and that inferior wall also, because it's fed by the right coronary artery, can involve a right ventricular infarction, and right ventricular infarctions are treated totally different than left ventricular infarctions. Here we end up seeing the inferior wall. This is another view of it, fed by the right coronary artery. And on an EKG again, tall PT waves, ST elevation, 2 string AVL. And this is an example of where you have a combination with an inferior and a lateral. Septal, look towards the middle. You think about your chest leads. This is the two that are placed on either side of the sternum. And because the septum also contains the bundle of His, you can end up having some AV blockage, AV blocks, and it's fed by the left anterior descending, and you end up having a loss of R waves in V1 and V2. So that's the two we're talking about. And you can see the ST elevation there. Anterior is the front portion of the heart, V3, V4. Again, it's fed by the left anterior descending. And this is the one that has the big problems with patients going into cardiogenic shock. And often bundle branches, because that's the portion that's fed by this artery also. You're right in the bundle. The worst one is this blockage right at the top here, where it's right at the left coronary artery. It's called the widow's maker. And you can guess why. You're knocking out the whole anterior lateral septal portion of your heart. That's a good portion of muscle mass that you end up losing. And here you can see V3, V4 having very tall T waves, very much ST elevation. Looks like there's a little bit of septal involvement also. So if we look at V2, V4, you can end up seeing the progression until you end up with a huge Q wave being present. Posterior, also known as the infrobasal. I don't know if I have that on your notes or not. It's the back side, and this is partially fed by the left circumflex, and it's also fed by the right coronary artery. This is one we can't see on a direct changes. We can look for reciprocal changes in the anterior leads, V1 through V4, where you would have tall R waves and ST depression. But if you have an inferior MI, you should always not only think about right ventricular infarction, you should also think about a posterior wall being involved. And that's the posterior there. And we would do a posterior leads, V7, V8, and V9. I got a picture of that, but that's basically looking on the posterior side, just continuing on, basically mirroring V3, V4, or V2, V3, and V4. You can have a right ventricular infarction. We said with an inferior, you should always think that. You end up having persistent hypotension that doesn't respond to fluids. The lung is fine because when the right ventricle doesn't function effectively, there's no pulmonary involvement, but it's all backing up into the circulation, so you end up things like JVD and hepatomegaly and ascites and stuff like that. And this is the posterior descending, which you end up seeing that branch being blocked. And we would look at for right. That's for right ventricular MI. So this is just a summary on one page for you of all the different leads. So let's talk about bundle branch blocks. How much did Mary cover about bundle branch blocks? Did she talk about anything about them? Okay, if you remember, there's a right and a left bundle branch. The right bundle is pretty simple. There's not a lot of muscle mass to deal with. The left bundle actually branches into a couple different, what we're going to call fascicles. There's a septal portion to it, and then the left bundle also branches into an anterior, into a posterior fascicle. So it's basically sub-branches of that bundle branch. And each of them can end up having a blockage where the current going down that portion can't continue and has to turn around. What ends up happening is you end up having a widening of the QRS complex. That's part one. So a bundle branch block will always have a widening of the QRS complex. If it's greater than 0.12, which is the maximum for the normal value, we got to look then as to whether, back up. A widening of the QRS complex usually means that you end up having a bundle branch block. That's assuming that the origin of the beat is supraventricular. In other words, it's not a ventricular beat, because a ventricular beat will also have a widened QRS complex. That's kind of the nature of it. But if I have a sinus origin and I have a widened QRS complex, that's telling me that I have a bundle branch block. And the block bundle will last to be depolarized because it's got to come back around again. Okay. We look at V1 or MCL1. That's why they use MCL1 in a coronary care unit. And we look at the terminal portion of the QRS complex, and we're going to use what we call the turn signal theory. If you think about which way you flip your blinker, it's going to tell you which way the block or which bundle has a block. So I look at my end of my QRS complex, what is called the J point. It's the very end of the QRS complex. I then move back one box into the QRS complex, and I see if that portion of the QRS complex is pointing upwards, then it's a right bundle. If I want to turn right, this is drawn on the wrong side of the steering wheel, like the blinkers on your left-hand side. If I turn right, I would flip it up. If I turn left, I would flip it down. My blinker's on the opposite side of the steering wheel, so that doesn't pertain. But that's the logic behind it. So this here would be a right bundle branch block. This would be a left bundle branch block. Go to the J point, move back one box. Which way is the QRS pointing? If it's pointing up, it's a right. If it's pointing down, it's a left.
So the only way we know we have a bundle branch block is just that widening complex.
And we look at V1. And this is what it would look like. You would end up having what are called rabbit ears. I have an R prime or S prime. I have two distinct positive deflections in this lead. Okay. So I have a wide QRS. I look to the J point, then I move back one, assuming this is V1, and I go look. So which would it be? Your right bundle branch. So here's my right bundle branch, V1. I have a positive deflection moving back into it. Left bundle, I have a negative deflection. Basically what is called the QS wave. So I have a wide QRS complex, greater than 0.12, and then V1, what is it telling you? Right or left? It's a 50-50 shot. Left.
Okay.
Wide QRS complex, greater than 0.12. Go to the J point, go back one box. We have a right bundle branch. Can everybody see that? See where I'm gaining this? Sure, Dean. That's what I live for. Is the QRS complex wide? Do I have wooded bunny ears? Go to the J point, which is the very end. Go back one box. Is that wave pointing up or down? So because it's pointing up, it's got to be a right bundle branch. If it's pointing down, it'd be left. Yeah, let's talk about electrical therapy. There's two big things. When we talk about, people use the term shock the patient. Well, that's really a bad way to look at it because you can either synchronize this or do asynchronous. So defibrillation, we're not syncing it to anything. In cardioversion, we're identifying the R wave and syncing that electrical energy being released at the point of the R wave. Defibrillation is basically a large current that is passed through the heart. The muscle then is thrown into simultaneous refractoriness with the hopes that the impulse will then, the sinus node will kick back in after a few seconds, and we end up having successful defibrillation. The only way to alleviate ventricular fibrillation is to defib the patient. Most of the old defibrillators, and you probably will not see them anymore, are monophasic, meaning that they go from one pad to the next pad. Most of the ones commercially on the market now are biphasic, meaning they move from each pad to the opposite pad. So two pads are placed, one below the right clavicle, one in the lateral portion of the chest, the precordial area, and in this case they would move opposite each other. Okay. And most implantable defibrillators are biphasic in nature. When in doubt, we defibrillate at the maximum energy. Biphasics typically start off with a little bit lower energy than monophasic, but it really depends upon the brand of the defibrillator you're using. In physio control, the life packs, which you might see in some of the units, they recommend the dosages of 200, 300, 360. So it's sequential. If you have a Philips, it's 150, 150, 150. So how do you know? You just got to know which piece of equipment you're ending up using. When in doubt, use the maximum energy. Pediatrics, normally it's not a big issue because they don't normally have a cardiac problem. Their origins are typically respiratory in nature. And joules are 2 joules per kilogram, followed by 4 joules per kilogram. If you're using paddles, we're really important to have firm pressure. Now we use pads on everybody, and so long as those pads have good surface contact, it's not an issue. It actually speeds things up when you have the pads on because you don't have to recharge or regoop the paddles and replace them into the spot. You can see there's a difference in size and diameter of the electrodes depending on if you're dealing with adults, children, or infants. And there actually have been case reports, this is kind of goofy, specifically with cardioversion more so than with defibrillation, but both are possible, where there wasn't good contact. Somebody took the resuscitation bag and laid it next to the patient's head to step back. And in the process, what ended up happening is it created an oxygen-enriched environment. The defibrillation arced and the patient caught fire. Actually, there's a little bit more of that story. There was some nitro paste there that was actually ignited. But bottom line is that the recommendation is when you defibrillate or cardiovert somebody, physically take the bag and hold it back. Make sure there's not any chance of that. We said right upper sternum, or right of the upper sternum below the clavicle, left nipple basically in the anterior axillary line. And obviously when we're discharging, the person who is responsible for releasing that energy has to make sure that everyone is clear. In defibrillation, we have the synchronized button turned off. This is the, yeah. I'll have to check that. This is basically it. Right below the left nipple. Probably is mid-axillary, right. We used to use, when we had the paddles, we could actually just put the paddles onto the chest and do what we call the quick look, to be able to identify them. Like I say, now we just use pads, so that's kind of dated. AEDs can be used, children above the age of 8 can be used in a younger child, if you have a dose attenuator present, and the pads that are involved, I kind of understand that I'm dealing with a younger child versus an adult. They're fully automated. They're not for cardioversion. They're strictly for defibrillation. And you just gotta be careful you don't put the pads over the implanted devices. The way these things work, the first step is always turn it on. Sounds like a big duh, but that's the simplest thing to end up doing because it'll give you prompts as far as what you need to do next. Next, I want to attach the AED to the victim's chest with electrode pads. You basically put the pads on first, then plug the cable into the box, into the AED itself. Once that's plugged in, it will go ahead and begin the analysis of the rhythm. Most of them have automatic analysis. There may be an analyze button that you have to push. If it recognizes a characteristic rhythm, a certain width and height, it'll say, "Oop, that's either VTAC or VFib. I'm going to go ahead then and charge the appropriate level of energy." And every brain is different. And then once it charges itself up, it asks you to go ahead and push the shock button, making sure that nobody is adjacent to it. It's really a pretty simple process. An interesting story was when they first put AEDs on the market, they had a little tape recorder on the inside to capture the surrounding noise, whatever, because they wanted to go back and analyze it along with what the rhythm was showing at the time. Anybody want to guess what the most common phrase was that they heard on the tape? Oh shit. If you get a no shock advised message, that means that the patient has a rhythm that is not shockable, and we're going to call that either PEA or asystole in the face of a pulseless patient. In that case, we just do CPR. In fact, what it'll end up doing is have you do CPR, and after 2 minutes of CPR, it'll have you pause and recheck again, reanalyze the rhythm again. If the patient is not breathing but has a pulse, we would do rescue breathing. And if they have a pulse and they're breathing adequately, we just basically place them in recovery position. Cardioversion. Cardioversion is different than defibrillation. They're both the application of electrical energy, but cardioversion is done with a specific purpose in mind. It's used for any tachycardia, be it atrial, junctional, ventricular, any tachycardia can be treated. But it's also used for a couple of atrial dysrhythmias, atrial fibrillation, and atrial flutter. In fact, atrial fibrillation that's persistent will actually find that we do elective cardioversions. Has anybody been on a cardioversion? Okay. You remember what the underlying rhythm was?
No.
Okay. We synchronize this release of energy to the R wave. It's usually using a little bit less energy, and we can keep cardioverting. This says up to four times, but you can actually go even further than that. Often the patient, especially in the elective process, is sedated or given something like propofol so they don't remember the process. And obviously part of the cardioversion is the downside is I can throw them into VFib. Oops. In that case, you need to go ahead and have resuscitation equipment available. And I may have mentioned this to some of you I may not have. The first thing that you want to do is think vomit, vital signs, oxygen monitor, IV 12 lead. So that's kind of how you should approach anybody who you're suspecting of a cardiac problem. The AICDs, the implantable cardioverter defibrillators, are used for patients who are at risk, either due to prior history, having a cardiac arrest due to VF and VT, or episodes of recurrent ventricular tachycardia, and they wear a medical bracelet and tell everybody that they have an ICD present. And if you ever see one on a patient and it's a little bump that is raised, usually they put it on the left, right below the left clavicle. You can identify it. We don't do precordial thumps anymore. You can ignore this slide. In theory, a witness cardiac arrest, when you don't have a defibrillator available, I'm not sure why you would have a patient monitored without a defibrillator available. But pacemakers, there's electrodes that are necessary, along with something that's going to generate a pulse. The electrodes typically that we place on a patient, the pads that we place on a patient, both have the ability to be cardioverter defibrillator pads as well as being pacing pads, placed in exactly the same place. And we would pace anyone who has a symptomatic bradycardia. That bradycardia can just be sinus in nature, or it can be heart block. We typically only overdrive pacing in one instance, so I'm not worrying about it. And you can erase this one. You no longer pace asystole. Here's what it looks like, and you can see it's just a wire then that is placed into one of the large, the subclavian vein, and threaded back into the heart. We typically will see in the ICU, or we'll typically see in the ER, transcutaneous pacing, where we're just placing a pacer on the outside of the chest. When these first came on the market, the sales people for Zoll or whoever was manufacturing it would bring in lunch to the ER and take off his shirt and overdrive pace himself and say, dude, you gotta find a new job, because that is just too weird. Typically what we end up having are the transthoracic pacers or cardiac pacers, which are ones that are permanently implanted. Sometimes we have the pacing just pacing the ventricle. It also can be set up so that the wire paces the atrium, pauses for a second, and then gives an impulse to the ventricle, so you have ABC sequential. And we can identify a pacemaker being present by a vertical line at the beginning of the QRS complex, or in the case of an atrial pacer at the P wave. And because the origin of that beat starts typically in the ventricle, it's going to be a wide complex. It's going to look funny. So look for that pacing spike, and here's a picture of it. You can see this vertical line, very narrow, followed by a QRS complex. It's a ventricular pacer. Okay. And this is an example of what we call loss of capture. I have a pacing spike present but no QRS following it. That's not good. Either the pacing wire is not placed correctly, or perhaps the amperage is not set. Two things we set when we we set up a pacemaker. We set the rate we want it to fire at, and then we basically increase the milliamperage until I see capture. That is capturing each and every time. So going back to our analyzing of the rhythm strip, we're going to look at the rate, whatever method you want to use. We're going to look at the rhythm and regularity, look at the R to R. Is our distance between each R the same? Is the distance from the origin of a P wave to the next P wave, is that consistent? If it is, then it's a regular rhythm. We can look at the P wave. Is the P wave present? Is it absent? Is it upright? Is it inverted? Do they all look the same? Is there more than one P for every QRS? Oh, good God in heaven. And then we look at the PR interval, we look at the QRS, and we look at the QT, and go on from there. And look at the ST segment, is it elevated or depressed? Look at the T wave, is it upright, inverted, tall, flat? And look at the origin of the pacemaker, and we'll talk about the clinical significance. We talked about this previously, disturbances in automaticity or disturbance in conductivity. Disturbances in automaticity would mean that something other than sinus node is probably the origin of the beat. Disturbances in conductivity means that there's or blocks would be an example of that. So here I have different things, because each of these areas can have automaticity. And let's talk about the various sinus rhythms now. Normal sinus rhythm is pretty easy to identify. P to P is regular, R to R is regular. Rates somewhere in the range of 60 to 100 beats per minute. There's a P wave for each QRS complex. It's upright. They all look the same. PR intervals within normal range. QRS is within normal range. It's a normal sinus rhythm. This is hopefully what we're in the majority of our life. That's a good thing. Okay. Pacemaker site is the sinus node, and all is well. There's some different pictures that are there. Now, these have some other things involved, like some ST depression and ST elevation, but it's still, the underlying rhythm is still normal sinus. Agreed? So don't get tricked by the fact that I have some ST elevation. It may be a sign that I'm a normal sinus, but I have some ischemia going on there. If the rate is less than 60, I'm going to go ahead and call that a bradycardia. Sinus bradycardia is a P wave, one P wave for every QRS complex. The P to P is regular, the R to R is regular. The PR intervals within normal range, QRS complexes within normal range. Folks that are well conditioned will have a normal sinus bradycardia. They'll have a rate less than 60. Me, that'll never happen because I don't believe in conditioning. So, you might also get a bradycardia if there's some interference with some of the conduction involved. You might see an inferior MI, or if there's an increase in vagal stimulation. So, for instance, you'll see a patient who you're suctioning, who you, because there's a lot of vagal receptors near the carina, you can end up having a patient becoming sinus brady. And the thing we want to look for, is this significant? Is this something which is causing a reduction in peripheral perfusion? If they're symptomatic, meaning they have hypotension, they have chest pain, they have loss of consciousness or poor response, cardiac output that's reduced. The treatment for this is atropine. And atropine is given in a 0.5 milligram increments up to a max of 3 milligrams, basically. So you can give it up to 6 times. 70 kilogram man, 0.04 works out to about 3 milligrams. If the bradycardia is not resolved from the atropine, our next step is to look at either pacing the patient or using a vasopressor to speed up the heart rate. Epinephrine, running at 2 to 10 mics per kilo, 2 to 10 mics per minute, or dopamine, running at 5 to 10 mics per kilo per minute. This treatment is true for all symptomatic bradycardias, more than just sinus, as we'll find. Exact same treatment, regardless of the origin of the beat. If they're bradycardic and they're symptomatic, I'm going to treat it with atropine first, and then either pacing or using a vasopressor to try and speed up the heart rate. You good on that? Yes, Liz.
So, what if it's like 30, you know, in an ICU room,
No. Well, first of all, they have a pulse, I'm assuming, with that, so we wouldn't start CPR. If the bradycardia remains, even though you start giving them some oxygen and you stop suctioning, then I would call the rapid. Typically what ends up happening with vagal stimulation is once you stop the stimulation, it'll come back up. But if it stays there, yeah, that's especially if you're starting to see things like the patient having a change in level of consciousness, something that's symptomatic in nature, complaining of chest pain. Yeah, Dinah.
Should we know the dosages?
You should know 2 to 10, you should know 5 to 10. Yes. And a 0.5 milligram up to a max of 3. All symptomatic bradycardia is going to be treated that way. You can ignore this one. I don't like it anymore. Normal sinus, sinus brady, sinus tac. Sinus tach means that it's a normal sinus rhythm, but it's faster than 100 beats per minute. P to P is regular, R to R is regular. 1P for every QRS complex, meaning that the sinus node is the pacemaker. The PR intervals within normal range, QRS within normal range. This is really where we got to figure out what the cause is. It may be simply a response to hypoxemia, a response to pain, a response to anxiety or fever, and you treat the underlying cause. So if they're hypoxemic, fix the hypoxemia. And here's some examples of sinus tachycardia. P's are all looking the same. It's a normal looking P wave. Here's a normal looking P wave, a little bit of ST depression, but other than that, it's, again, sinus tach. Narrow complex. Okay? Some other sinus dysrhythmias. Sinus arrhythmia, where the SA discharges irregularly. Sinoatrial block, where I basically have a P wave that didn't get through. You just have a P wave with no QRS complex associated with it. And sinus arrest, where I end up having just no P wave, QRS kicks in, and we have an escape beat, either a nodal or a ventricular beat while you're in. Sinus arrhythmia, remember, is normal. We see this a lot in kids, that there's an alteration in the R to R depending upon their phase of ventilation, so that during exhalation they end up having a little prolongation of the R to R, and in inspiration it goes back to a normal R to R. You see this going back and forth, especially in kids that are sleeping. It's benign. Here's a sinus block. P, R to R is regular, R to R is regular. Hey, where's my P wave? Got blocked out. For whatever reason, it didn't get conducted through the atrium. Picked itself back up with its normal pacemaker. So that if you were to plot out using calipers the R to R, you would see that there's a P wave missing there. And this is sinus arrest. It just it doesn't map itself out. It's a little bit different than the sinus block. I won't test you on these three, just so you know. Goes along with our video we started with.